first session of the new cycle. So we're gonna begin with our introductory talk, for the buprenorphine. Um, and I'm gonna pull this up. I hope everyone can see it. Great. I got a thumbs up from Rana, so I'm going to go with it. We're really gonna talk about this is the introductory slide, talking about just introducing opioid use disorder treatment, some basic principles as well as their barriers. We're gonna start today by summarizing some of the key findings of the national opioid epidemic, and really start looking at how they inform our clinical practice, right? And we're gonna talk about treatment options, both psychotherapeutic as well as pharmacotherapeutic, what works, what doesn't work, what's recommended, what's not, and then go a little bit into barriers to treating opioid use disorders in our clinical practices. As I begin, no disclosures from myself, of course, or from any member of the team in the past or in the present. So, the White House has declared opioid use disorder an epidemic. And right now, right, I think we're kind of living in the midst of what HIV and hepatitis C literature often refers to as a syndemic, right? Which is where, two different epidemics collide. And right now we're seeing kind of this collision between the opioid use disorder epidemic and, of course, the COVID-19 epidemic. And when the two come together, it's increasing the overall healthcare burden and outcomes. So it's really quite a challenging time we're living in. And for our patients with opioid use disorders, it's an even more challenging time, right? The patterns of substance use availability, patterns of substance availability have changed. Patterns of even harm reduction services have changed. What's available, what's not available, what they're able to access, what they're not. There's also this added issue of loneliness, social isolation, which can also worsen outcomes. So I think this is really a challenging time, and I think I'm glad that we're all here to talk about how we can best help our patients. This is really the third wave of the opioid epidemic. The first wave really started a couple of decades ago. We started noticing in the early 2000s that over the past 10 years, emergency department visits related to some of the prescription opioids, specifically oxycodone and hydrocodone, had skyrocketed, gone up by 400%, 500%. And that continued to rise, right, between 2003 and 2009. Then we started passing legislation trying to curb it, more provider education, more naloxone co-prescriptions, and those rates, right, started to kind of plateau, maybe and decrease right around 2010 or so. But that's when, look at that orange line, that's heroin. That was sort of the second wave of the opioid epidemic. Heroin rates skyrocketed. And in fact, in 2009 and 2014 or 2013, opioid overdose mortalities related to heroin went up sixfold, because many people who were previously dependent on prescription opioids and maybe they were suddenly cut off, unfortunately turned to street heroin. And then now we're kind of in the midst of this third epidemic, which is what are known as high potency synthetic opioids, primarily illicitly manufactured fentanyl, carfentanil. And we're seeing that. And unfortunately, we're also seeing this like combination of people using these high potency synthetic opioids in combination with other substances, very commonly methamphetamine, right? So I'm gonna keep going. So while the overdose mortality related to prescription opioids has started plateauing, really the overdoses related to fentanyl, carfentanil, as well as methamphetamine have continued to rise. This is just some recent New Mexico data looking at unintentional overdose mortalities. Prescription opioids remain the most common here in New Mexico, but really heroin and methamphetamine have kind of climbed up the ladder. And very often we find benzodiazepines also involved in overdose mortality. This is just another way of looking at it. And you can see again the two lines that have rose precipitously, right? One is the fentanyl analogs, that's the blue line. You can see from 2015 to 2018, significant rise. And the other, of course, over the same time is the green line, which is methamphetamine. And unfortunately, we're finding increasingly these two substances are found together or used together by our patients. So kind of moving forward, some of the adverse outcomes associated with the opioid epidemic, opioid use disorder, right, has consequences. It has cost. It's been shown that individuals with opioid use disorder, not in treatment, compared to someone in general population, are about 6 times more likely to die as a result of their illness. Some of the other medical risks, of course, include hepatitis C, which is so common. 60-70% of injection users may have hepatitis C. HIV also kind of not as common, but certainly rising rates. Of HIV also seen in people who inject drugs. Mortality rates, as I mentioned, are significantly increased, and some of the major causes of death include things like drug overdoses, suicide, violence, accidents, infection, chronic diseases. There are also multiple psychosocial risks, including low employment, right? Crime. And oftentimes the crime is related to needing to obtain the substance, right? So if you think about heroin, if I have heroin use disorder, I'm needing to use heroin 3, 4, 5, 6 times a day. I might be waking up in withdrawals or fearful of going into withdrawals, which feel horrible. So my energy is kind of devoted to what do I do to treat my withdrawals or to not go into withdrawals. And that's often where the low employment and crime come in, right? And ultimately significant costs, both medical as well as overall costs, are associated to opioid use disorder. Switching gears a little bit, going into kind of the treatment perspectives and considerations, right? Both psychosocial as well as pharmacological. So let's start with some kind of, let's start with some historical perspective, right? Over the years, substance use disorders, addiction has been viewed and treated differently, right? Historically, and I think unfortunately this still continues to be a case, right? Where addiction is often seen as a crime. Viewpoints that are focused on the impact use of society, right? And certainly here in the United States, there's a long history of it, even dating back to the temperance movement in the 1800s, as well as more recently the war on drugs. And I think there is also, sort of concerning data about who this kind of war on drugs is disproportionately likely to impact, which might be individuals from ethnic, sexual minorities, as well as people from low socioeconomic statuses. There is also this idea that persists of addiction as a moral problem or failing, which is a view that addiction is the failing, right? That I'm somehow weak. My willpower must not be strong enough. I must have a weak character, to lead to or develop addiction. Increasingly, and certainly in the kind of Western medicine, and this is something that's really been advocated on by National Institutes on Drug Abuse, which is the idea that addiction maybe is a disease, right? That is caused by a disease process, kind of a cause and effect relationship. It's driven by changes in the brain, changes in genetics, etc. And I think probably a more encompassing view of taking it is addiction as a complex, multifaceted condition, which is the viewpoint that addiction has psychological, physiological, as well as social and environmental contributions, right? So it's ultimately greater than the sum of its parts, and kind of a more holistic view of substance use disorders. And indeed, data really supports that addiction is a complex biopsychosocial process. We know that there's a genetic predisposition to many substance use disorders, including opioid use disorders. And we know that the contribution that comes from the genes is no different than the genetic contribution for other chronic illnesses, such as diabetes, hypertension, and asthma, which I'll show here in the next couple of slides. There is also a profound psychological component, right? Where the more substance is used, the brain chemistry is altered to a point where it essentially hijacks the brain and affects the brain's ability to think, alters feeling states, as well as impacts the perception and behavior of the user. And certainly there is a sociological component where, anytime a person develops a substance use disorder, right, interactions with family as well as other members of the society are altered, misinterpreted by the user. And those observing the behavior result in systematic feedback loops, right, that reinforce use. Also, socially, we know that there is profound, for example, links between adverse childhood experiences or complex trauma and development of substance use disorders. So ultimately, it's this multifactorial thing, right? Combination of biology as well as environment and something called epigenetics, which is where environmental cues, especially early in life, can influence certain genes turning on and off, which in turn can further influence the development of a addictive process of a substance use disorder, right? And certainly along with that, the drug itself plays a role. It itself is a risk factor, including how is it administered, what type of a drug is it, what is the effect of the drug, along with things like early use, availability, and costs. All of that impact brain mechanisms leading to an addiction process. So, a very well accepted idea is that substance use disorders, including opioid use disorders, are chronic conditions that require chronic ongoing treatments. We know from lots of data that despite the messaging we sometimes hear in media or in public discourse, recovery is possible. And it is a process of change through which an individual achieves improved health, both physical as well as psychological wellness and quality of life. And recovery may or may not include sobriety, right? So someone can be completely sober and may still not have met some of those key components of recovery, including health, nurturing relationships, the sense of purpose, involvement in the community, stable housing, right? Whereas someone could still be using a substance, but still work towards recovery. So the two are not mutually exclusive. And there is lots of literature on it, lots of really interesting literature. And if someone is interested, I'm happy to send links or articles on it, right? So as I was mentioning, compared to other chronic illnesses, substance use disorders display similar genetic impact. So in other words, the contributions of environment and personal choice are comparable. It's roughly 50. About half the contribution comes from genes, and the other half comes from the environment. Interestingly, we often think that people with substance use disorders aren't going to stay in treatment, they're not going to do well in treatment. What data show is medication adherence and even relapse rates are similar between substance use disorders and other chronic illnesses. And therefore, long-term ongoing treatments have been proven to be the most effective, right? Because if you just provide episodic treatment to a chronic illness, we can't expect the patient to succeed. Just like if someone has diabetes, we wouldn't think about just treating them for 28 days or 7 days and not think about treating them on an ongoing basis. So it is with our substance use disorders. And this is just a slide showing percent of patients who relapse. Again, we have this idea that people with substance use disorders often relapse, but here you can see that drug addiction has relapse rates that are similar to things like diabetes, hypertension, and asthma. So I think a lot of this then, so why do we continue to harbor these different views? And I think stigma ultimately is a major factor, and stigma presents as a major barrier to recovery, right? Individuals with substance use disorders are still perceived, even in 2020, as having a moral weakness or character flaws and as being untrustworthy or criminally involved. There are recent surveys showing many people think that people who have substance use disorders should get less priority in things like healthcare, housing, and employment, right? And ask yourself, this is something for all of us to reflect on, if we've ever had any of these thoughts about our patients, right? And medical professionals are not immune from this, from viewing addiction negatively. Recent study of medical perspectives found that respondents said people with substance use disorders should receive less priority in healthcare, that their condition was their fault. People we know with addictions tend to internalize the stigma, which ultimately also leads to worse outcomes, including less likely to seek and stay in treatment, worse mental health, worse physical health, reductions in employment and housing, and poorer support system, as well as learned helplessness, right? Why should I bother when I'm never going to succeed? So I think something we all should be doing at all times is working to combat stigma. And I know that's a talk we have coming up. So we'll go into more detail in the next week or two on that topic. So general treatment recommendations. Again, the first recommendation is treatment should be continuous. Remember, it is a chronic disease needing a chronic treatment, right? Rather than episodic, and focused on the whole person, not just their use behavior. Treatment should ideally, as a gold standard, include a combination of medication, learning new skills, right? Like relapse prevention skills, refusal skills, social support, building up the social network, as well as chronic care management. Goals should be improvement, not cure, because relapse or episodic use is the rule and not the exception, right? Just because someone has a recurrence of use does not mean they've failed treatment. The best thing we can do is keep our doors open, engage them in treatment, and data really suggests that if we do that, we're really working to improve the outcome of our patients. And we know that using evidence-based treatments leads to substantial improvements in reductions of use, increases in personal health, increases in social functioning, reductions in threats to public health and safety, as well as reductions in monetary costs to individual and community. So recovery, right, works across many aspects of wellness. And we've sort of talked about this, and this includes essentially all the components of recovery. Big part of it is relationships, right, within family, within peers, within community. And really, ideally, we can work towards strengthening those relationships. There's lots of literature on that as well. Positive community participation, something that gives an individual a sense of purpose, right, meaning in life, as well as stability of housing and health. And those, again, are all the components of recovery. And according to SAMHSA, if we're able to provide all of these, if the patient works towards all of this, ultimately, it helps foster hope for the future. And hope really is the cornerstone of recovery. And this can be a lifelong process. Now, I'm gonna go into some specific interventions. Psychosocially, what works, what doesn't work. So historically, there are two different models, right? Historically, we followed the abstinence model, kind of the cold turkey model, which emerged out in the 1930s, assuming that abstinence is the best. It is the most effective way to treat addiction, right? It's kind of the Minnesota model, which historically was followed by Hazelden and Betty Ford. Interestingly, now, both of those facilities have opened up and have allowed medications for individuals with opioid use disorders, realizing that there is overwhelming data supporting that outcomes are better when we use our medications for opioid use disorders. AA and 12-step, right, can be importantly huge parts of recovery. But sometimes our patients with opioid use disorders who are on medications have a hard time feeling accepted, right? And they can often feel judged. And often I work with them using something called 12-step facilitation. And really one of the messages is try out different groups, right? Try out, see whom you connect with, what members, may be more open to you, where you can be honest, where you can be yourself and feel safe. And I think that may be one part to still encourage individuals to explore AA, which really can be a part of recovery. Since the 1990s, the predominant model has been harm reduction, where priority is placed on reducing harm of substance use disorder, right? Similar to other chronic disease issues and relapse prevention skills. And it assumes that substance use disorder can be treated by gradually decreasing use over time. And it doesn't have to be kind of cold turkey abstinence model. Users can be in treatment while continuing to use. And I will point out that when it comes to opioid use disorders, this really is the standard of care right now in 2020. That just because someone continues to use a substance doesn't mean they should be discharged from treatment. Because when we discharge someone from treatment, outcomes worsen, right? Medications are encouraged. Stages of change, and we have an entire talk on this, so I'm not going to be going too much into it. But the key point here is that outdated perspective is that patients have to be ready for treatment. The reality is that our patients can be anywhere along this spectrum, and they can go back and forth as we treat them. And we try to match them, work with them where they are, meet them where we are, and do our best to engage them. And I think that really is the key. And here we've used some strategies, some global strategies to use based upon what stage of change a patient is experiencing. Let's see here. So what is not recommended? These are the things that we don't recommend. Detox alone has never been shown to improve any long-term outcomes. So keep that in mind. Individual psychodynamic or psychoanalytic therapy only. Unstructured supportive individual therapy. Unstructured or process-driven group therapy. Process-driven group therapy takes tremendous skill to do right? And it hasn't really shown evidence with opioid use disorders. Discharge from treatment in response to relapse or ongoing use, as I was mentioning. Confrontational approaches, right? As used by therapeutic communities overall for individuals with opioid use disorders don't carry a lot of evidence. Acupuncture alone, acupuncture, relaxation therapy, all of these can be good adjunctive modalities, but by themselves haven't shown to be very effective with opioid use disorders. Same with urine drug screens only. If we're just monitoring without intervening, it's not as effective. These are some things that are evidence-based for opioid use disorders. Certainly motivational interviewing, both individual and group. Cognitive behavioral therapy, which can include things like harm reduction and relapse prevention techniques and skills. Contingency management, right? Voucher-based reward system, probably the most evidence-based psychosocial treatment across substances. Community reinforcement approach, also extremely evidence-based. 12-step and peer support, right? But with that caveat, with that caution that I was mentioning earlier. Structured family and couples therapy, right? Including, which is the primary intervention for individuals under the age of 18. Next, in the next couple of, we have about 6 minutes left, introducing medication assisted interventions. Increasingly, a caveat here is that the nomenclature has changed. Back in the day, we used to say opioid replacement therapies. Well, we found that when we use the word opioid replacement, it actually led to like people feeling inherent bias, or that implicit bias rather, towards it. So we moved towards medication assisted interventions, right? But as data started mounting that for opioid use disorders, medications really play the central role in treatment. Many people are now starting to use MOUD, or medications for opioid use disorders. And that's probably the most commonly used nomenclature right now, right? And we've got 3 medications approved by the FDA for opioid use disorders, which include methadone, which is our full mu agonist, can only be dispensed from a federally licensed opioid treatment program. Buprenorphine, which is what this whole course focuses on, and which is what Bear Valley is going to start doing out of their ED. So kudos for that. I think that's a huge public health win, as well as naltrexone, both oral and injectable. And buprenorphine, again, has been around since 2000. It is a Schedule III opioid, and the Data 2000 Act allows physicians, and now the CARA Act also allows nurse practitioners as well as physician assistants, after going through a special training and obtaining what's called a buprenorphine waiver, they can actually prescribe it directly out of their offices. And eventually people can build up to treating up to 275 patients at a time. And we're gonna go into, of course, a lot more detail with buprenorphine over the next 3-4 months. But I wanna end here by talking just briefly about significant treatment barriers, right? Psychosocial treatments, while effective, especially in rural parts of the country. Nationally, there is a shortage of about 50 for mental health care providers in general, and it's even more pronounced when we talk about behavioral health providers who specialize in substance use disorders. There's also stigmatization, right? There's also things like low compensation, high turnover, high burnout rates. SAMHSA has really supported building up and supporting behavioral healthcare workforce, especially around SUD treatment. Of course, methadone can only be dispensed through an opioid treatment program, and rules are tight, right? You must go in, for example, at least 6 times a week when you start treatment. There's also things like stigma, being able to even find a clinic where you live. So that can pose significant barriers. And in theory, office-based treatment with buprenorphine can eliminate those barriers, right? And allow for that continuity of care, allow the patient to live their lives, engage in recovery activities while receiving treatment. But availability remains a concern. So if you look at it, this is a busy slide, but especially in rural America, over about 58% of counties don't have a single buprenorphine provider, right? The good news is that it's improved. Between 2016 and 2018, patient capacity for buprenorphine went up, over doubled. And we've certainly seen that here in New Mexico through many of our efforts around the state, but there still remains a huge gap. Nationwide, only about 5% of providers have the waiver to prescribe buprenorphine. So this is something we have to continue to work on. This is just a map where all the counties that are shaded in white are counties that, as of 2018, don't have a single provider who can prescribe buprenorphine. So I kind of leave you with that somber thought and some references. And I will end here.